Just as they're trickling in, there's two more, I guess, diagnostic vital signs I just want to touch on briefly. And that's, everything go okay? No dead body?
I love radiology.
Is pulse oximetry and just briefly EKG. So the glucometers in this chapter, we're going to spend a lot of time with glucometers now. But pulse oximetry is a skill that is now within the EMR scope, super easy to use. So what we're reading is when we're looking at the oxygen saturation. Is remember when I talked about you got a red blood cell. And on that red blood cell, there's another, I guess, protein, right? Hemoglobin. That oxygen molecules bind to that hemoglobin molecule that is on your red blood cell. Really small. You also have oxygen that's kind of floating around in your plasma, but what we're measuring with the pulse oximeter is what percentage of that hemoglobin is saturated, has molecules attached. Okay? There's some things that can create false readings on the pulse oximeter. So for one thing, carbon monoxide, CO, has a much greater affinity for hemoglobin than oxygen. So if I'm in a carbon monoxide atmosphere, it will actually displace the oxygen molecule from the hemoglobin and attach. And when you put the pulse oximeter on me and read it, it's going to say 100%. Because all it's reading is that your, and I'll just say red blood cell is saturated 100%, but it doesn't know with what. So it doesn't differentiate carbon monoxide from oxygen. It just identifies as saturation. Does that concept make sense? Okay. We do have special meters that look just like a pulse oximeter. In fact, it's the same device that we can read where it will identify the percentage of carbon monoxide. But that's a topic for another day. So we put this probe on a finger, and some are a handheld device, some are hooked up to a machine, some are just finger clips. They're all pretty accurate. And it's going to give us a percentage. Ideally, we want our patients to be better than 94%. 94% or better. 96 is fine. Doesn't have to be 100%. Okay. In fact, right now, if I checked everyone in this room, we're probably going to see 95. Any smokers? Smokers might be a little lower. Yeah, but as long as you're better than 94%. Now, as you advance into something like emphysema or lung disease, you start to get chronically lower. So, if I put a pulse ox somewhere and it's 91, I would ask them, what's your oxygen? And if they have a history of COPD, I ask them, what's your oxygen usually at? And they'll tell you, oh, it's usually at 90%. Right. Or I run 89, 88%. That's normal. For most of the population, when we get less than 94%, we're concerned for hypoxia. And less than 94% is when we start considering oxygen therapy. So last week when we talked about like the nasal cannula, the non-rebreather mask, if I come in and someone doesn't appear to be in physically significant labored breathing, but their pulse ox is like 93, 94, I'll put them on a nasal cannula. And a lot of times we see that within a minute, the numbers back up 98, 99. Good. If I walk in and someone's, I can't breathe, I'm just going to put a non-rebreather on them even before I hit that. Just get the oxygen on, try to get that number. And that number can change pretty quickly, let's say over a minute. Anything that disrupts blood flow through where we're testing, so again, ice cold hands, or if you do a cap refill and it's really delayed, we're going to have an inaccurate pulse oximeter. So we can administer oxygen therapy with or without this. If they look like they're having trouble breathing, give them oxygen. If they're really struggling, give them a mask. If it's mild, give them a nasal cannula. And we can always change. So I've done it where I put someone on a cannula, then 3-4 minutes, their numbers aren't coming up, they're getting worse, we just switch it out with a mask. Or I put them on a mask, their numbers get better, they wake up, they start becoming more, better mental status, then I'll take the mask off, put them on camera and see how they do. Okay, does that make sense? All right, I'm gonna shut the PowerPoint off and we're gonna talk about patient assessment. I'm just gonna go off the top of my head here. The slides, how they bounce around are kind of confusing. So, scene assessment, we talked a lot about that in the earlier parts of class, like in the first week or two. Scene assessments, we're trying to identify any life threats or any threats to us, make sure the scene is safe. I heard a lot of talking today about, we're always worried about the guy with the gun, but hey, we're in the Northwoods, every guy's got a gun in their house. But I would say almost 9 out of 10 houses we walk in, that patient is within arm reach of a weapon. Does not mean that they're immediately threatened. So it's not the gun that's the threat, it's the person. So if a person has an altered mental status, they seem irritated, agitated, how many married people in here? Okay, do you know when maybe I need to go in the garage for a bit? Okay, so you kind of get where I'm going. That if you notice agitation in a patient where they seem like the guy at the bar that's, you can tell he's, okay, this guy's looking to start a fight, we just go somewhere else, right? It's the same thing in an EMS call. We see patients with that unusually irritated, they seem short, or they're yelling, get the out of my house, okay? Hey, someone called 911, I didn't call, okay? You just step out, I mean, more people are coming, ambulance is coming, you may say, patients, you just get on the radio, hey, patients very irritated that we're here, so we're stepping outside and wait for you guys to get here, maybe sign law enforcement. That's all we do, just go somewhere to get in our car, even if we gotta drive a block down, go drive a block down, wait. Or maybe they'll go unconscious and come back under 5%.
Jason, when you're going to, like, say you go to a house and you knock on the door, but say they live alone, like, are you just walking in, or are you waiting?
It depends. That's a really good question. So, we get called for an address, 911 hang up. So we really don't know what we're going to. Usually calls like that, dispatch is really good about launching law enforcement. That they're gonna send law enforcement. I would say, first responders never force entry into a house. In fact, even on the ambulance, we don't force entry. I'll let law enforcement do that. You think like those life assist buttons. So I would say the overwhelming majority of these life alert calls turn out to be false alarms. They bump their button. So they're taking a nap with it. They roll over, bump the button, and all of a sudden they wake up to their people coming through the living room. It wouldn't be unreasonable, they're getting ready, right? So what we would do on the ambulance is we start looking in windows, knocking, making as much noise as we can. Now, if I look and I see somebody on the ground, I'll notify, I'll get on the radio, hey, dispatch, we see a victim not moving on the, we're forcing entry. Depending on where the ambulance is, especially if it was an 86-year-old female, difficulty breathing. If it was, we need you to go to a house for, domestic, and we see someone laying on the ground, I'm not going. It's just, it kind of common sense type stuff, right? Okay. So, but when in doubt, never put yourselves in danger. A lot of the other scene assessment is trying to understand it has to do with trauma. It's the mechanism of injury. You'll hear this term. Mechanism of injury is how we try to use the forces that cause their injury. So I'll use, for example, like a car accident. That I know a person who was a T-bone accident where the patient's car was struck in their driver's door. It's a big mechanism of injury. That a door, the sides of the vehicle, don't have a lot of impact So a head-on collision, where people think those are bad, cars are designed to actually absorb that energy. It's not being transferred into the person as much. I get hit in my door, there's not much there to absorb that energy, right? So mechanism of injury is kind of, we're using kind of that scene assessment, that if I'm pulling up to a car accident, I see a driver's door that's severely deformed or pushed in, that's telling me that's probably a critical patient. So I don't want to get into that too much. I want to get into the actual patient assessment. So you'll hear terms like general impression of the patient, APU, and let's go through them a bit. So when we determine scene safe, we can go ahead and let's just assume we have permission to treat the patient. There's some things we're doing mentally as we're walking up to it. And you might hear the term sick, not sick. And that's my general impression. Where as I'm entering a room to make patient contact, my general impression is really basic. They're sitting in a chair, they're awake, and they're interacting with the environment, they're looking at me as I'm approaching. So that for me is already starting to lower some of my clinical red flags. That if they're looking at me as I'm coming through the doorway, what does it tell you? That they've got a heartbeat, they're breathing, right? So that's my general impression. And then as I introduce myself, hey, how you doing? My name's Jason, I'm with the ambulance. This is where I'm kind of getting what we call this APU. APU is an acronym that we're using it to assess level of responsiveness. So A stands for alert, V stands for verbal, P stands for pain, and U stands for unresponsive. So if I come in, Ian, he either responds to me verbally or even non-verbally by looking at me, he's alert. Okay? Now, keep your eyes closed until I yell your name. Ian?
Yeah.
Now he's alert to verbal. It took a verbal stimulation to get him to respond. What's the next one? So Ian, I yell at him, he doesn't respond. The next thing I'm gonna do is I'm gonna get somewhere I don't get hit. I'm gonna come behind him, and have you ever heard of the sternal rub? I'm not gonna do it for you. But a sternal rub is I usually take my knuckle and I rub it right along the border of the sternum and the ribs. It doesn't feel good. And so that's if I had to do that and I get now he's alert to painful stimuli. Or I'll kind of do this sometimes, I'll grab the tip of their finger and pinch it, especially if they look like they're gonna get violent. You know, I'll try to elicit some pain. And if I get a response or work pain, if I do all that and they don't respond, they are unresponsive. So I've done that in the first 2 seconds of patient. The next thing I'm gonna use is the acronym. I don't know, has anyone read this in the book? And there's gonna be a couple different acronyms that you may hear. So let's call, probably the easiest one, I call it XABC. So X, this has been now recently moved up to primary. X stands for examination, life-threatening bleeding. Okay, so do I see massive amounts of blood at or around coming up with the person, right? So what I mean by massive is if, and I'm using him, he's in a car accident, he's alert, but his face is covered in blood. Is it just covered in blood or is it actively pouring out? So if it's covered in blood, that's not a life-threatening bleed. All right, I'm gonna move into my ABC. But is he bleeding out of an artery or large vein? That basically a serious bleed, we don't check anything, we stop that bleed quick. So if his arm's bleeding real bad, I put a tourniquet. Leg, tourniquet. He's got a gash on his neck, hit it with my hand, stop. Okay. Then I move into my ABC. That's airway, breathing, circulation. I think the text might have used another acronym called MARCH, M-A-R-C-H. kind of the same thing, but MARC stands for massive hemorrhage, that's M, airway, respirations, circulation, head injury, hypothermia. So it's just kind of another acronym, but XABC is probably the easiest. So, like that, if I said Ian, and he says yes, I know he's got an airway, he's breathing, and it's, you know, now I might want to dig into quality a little bit, but I got those big three things checked off, okay? If he doesn't respond, I don't see any obvious bleeding, I go to airway. So if he's on the ground unconscious, I, step one, open his airway. We have a jaw thrust, head tilt, chin lift, and is he moving air? So remember, airway is just we're clearing the passage. And then B is he moving air in and out of the passage? That's breathing. And we don't move on to the next until the first one's taken care of. So if he is choking, I focus on airway. I'm lifting, abdominal thrust, chest thrust, doing all that to clear his air. Then, once I get his airway cleared, I might have to breathe for him. So then I don't move on until I get care. And then C is circulation, does he have pulses? Now, if I suspect a cardiac arrest, we're kind of doing this 1, 2, 3. He's not breathing, immediately I'm gonna check a pulse. He's in cardiac arrest, we initiate CPR. And then kind of nothing, right? So if the airway isn't good, let's say, what if Ian's gurgling? What are we gonna do?
Turn him on his side.
Turn him on his side, and let's say we've got some equipment. What's piece of equipment? Suction. Be it battery powered, manual powered, try to clear that airway. And then we get the airway clear, I'm gonna look, listen, feel, is he breathing? Let's say Ian's breathing 6 times a minute. Is that adequate?
No.
No, so I'm going to assist him. Now, what do I assist his breathing? Grab that bag valve mask, which we're gonna play with more. In fact, not next Wednesday, but the Wednesday after, it's just all lab, just hands-on stuff. So we're gonna start bagging, right? And then he's got, let's say we check pulses, he's got a pulse. So we got circulation here. Now I look at his skin color, and if he's kind of unconscious, I'm gonna move into what's called a rapid head-to-toe assessment. So rapid head-to-toe is after I've got airway, breathing, circulation taken care of, I'm gonna try to quickly find stuff that's immediately threatening to life. So I always start at the neck. Why not the head? Because everything that's immediately threatening to his life is his airway and breathing. This is where we have to be disciplined. So Ian's been in a bad wreck, and let's say he has an orbital fracture in his eyeballs. Now, I'm throwing that just to really, for shock value, because I've only seen that once in my entire career. So it's not, you're not gonna roll up on guys' eyes hanging out, but it might happen, but usually not. So he's got a massively deformed injury that I might tend to focus on. What's important is that I stay disciplined, because is that eyeball hanging out of his socket gonna kill him in the next few minutes? No. Absolutely not. So we'll worry about that guy later. We'll come back to it. So airway, his airway's open, he's either breathing or we got someone breathing for him, he's got pulses, I start at the neck at that point. With the neck, a couple things I'm gonna look for is the trachea midline. So the trachea, your windpipe here, and if he's conscious, I'm not gonna go grab his neck. This is, we're gonna assume unconscious. I can see his trachea's midline right now, but if he's laying on his back, I find that sternal notch. Boom, yep, it's midline. It's right in the center where it should be. If the trachea is displaced a little bit to one side or the other, where do we see it? It's down low, right here. If the trachea is displaced either right or left, that could indicate that he's got a very bad collapse lung. And air pressure is building up, actually pushing that trachea. If he's breathing, you may hear a term called tracheal tugging. And the reason this need to be checked quick is because the tension pneumothorax is like immediately life-threatening. So I'm going to hold on to the trachea just lightly and feel it while he takes a couple breaths. So that trachea shouldn't move. But if he's breathing, and I feel it tugging a little bit on me, that's called tracheal tugging, and that indicates he's got a really bad collapsed lung, probably moving to attention pneumothorax. I'm also gonna look at his neck veins, these jugular veins, and I should have left it up, and we'll look at pictures, maybe next week. But when we see these neck veins and they're really sticking out, we call that jugular venous distension, JVD. And JVD indicates a lot of potential bad things. Basically what jugular vein distension says is that my heart isn't empty for some reason. Collapsed lung, probably being or heart failure, where the right heart isn't getting blood pumped out, so it's backing up in the neck veins, but that's what JVD is. And I'm also looking for, here's another acronym, DCAP BTLS. DCAP BTLS. So, DCAP BTLS basically means I'm looking for any evidence of trauma. So what is DCAP BTLS? It is deformities. So is my arm not straight instead of make it look like a Z? That's a deformity. Does he have contusions? Which are, what's a contusion? Bruising, yeah. Deformities, contusions, and I gotta sometimes say it because I forget. But, A stands for abrasions. Everyone know what an abrasion is? Straight, yeah. Abrasions are more straight. P is penetrations, right? What's it? Puncture and penetrations. So does he have something sticking in him or a hole in him? B is burns. T is what? Tenderness. Tenderness. So as I'm, I touch something out. L is lacerations. That's a good repeat. Yeah. And then S is swelling. So looking for evidence of trauma. And obviously, some things are threatening, some are not. So if he's got a bruise on his neck, is that immediately threatening the leg? No. Do people with swelling leak either? Yeah, the swelling could be bad enough where it's impeding his airway, but I've already assessed his airway. Remember that if he had swelling that he wasn't moving air, I didn't move on. I'm not checking his neck, I'm focused on getting the conversation first. Then I'm going to go down to his chest. Now at this point, we really need to expose them as best we can. Now if it's 10 degrees outside and he's in a snowmobile wreck, I'm going to do a very modified, maybe open it up, get my hands in and feel. But, so we're going to look at the chest. Any evidence of trauma? Is it symmetric? I might take a stethoscope and I'm just going to listen right lung, left lung. All I want to know is he moving air or is he? It's not very detailed. Again, I'm looking for those life-threatening bleeds at this point. Then I move to his abdomen. In abdomen, I mostly just do a visual inspection. I just look at the belly. Do I see any abnormal swelling, and evisceration? And evisceration is where a bowel has been. We got a lot of stuff packed in our bodies pretty tight. We got, I don't know, probably some fat and muscle. Not much muscle. Maybe Ian's got more. 6-pack still on. But we've got all this stuff that's kind of packed in there. So if I cut that, and I cut through that muscle, and I cut through that pleura, your bowel is just going to come. Now, not like we see in the movies where they're hanging on to it, but you get this little open bowel that comes up. That's an evisceration. You could see, and I did have a call once where a guy eviscerated himself because he was trying to get the demon out. Colons could be, like we got there and his guts are sitting in his mouth. I have a demon out. Who was a demon out? Okay, it's a little hospital. Anyway. But you know, and everyone thinks, well, we're gonna see this massive amount of bleeding. Unless he were to cut like an artery in his gut, there's very little to no blood. Well, how many deer hunters again? And success, I'm sure if you're successful, you've had to dress a deer, right? Or as we say, good. And hopefully you put the shot in the wheelhouse. So let's forget about the gut shot ones, because those are different. But when you take the bowels out of the deer, when you cut that belly, is blood come pouring out? No, there's not much, wasn't there at all. It's the same thing with the human, right? So that's a real quick test. Now, your book is gonna talk where we palpate that belly. I kind of skipped that at this point. I'll tie that in probably next week, why we don't. Right.
Quick question.
Yeah,
Tell somebody's gonna go on internal bleeding,
how are you gonna tell if they have internal bleeding?
if you can.
Yeah, it's gonna be a lot on vital signs. I'm jumping ahead a little bit because we're gonna get into that a lot in the trauma class. Well, actually, I don't worry about internal bleeding because that's where the blood's supposed to be, on the inside.
You know what, that's a good point.
It's a joke.
Yeah.
But they start presenting with evidence of shock.
Gotcha.
So your body's trying to correct it, but you can bleed, you could probably bleed almost your entire body's blood supply in your abdomen without showing any evidence of bleeding on the outside. Your abdomen might get a little bit distended.
They won't change color in the face or?
Oh, yeah, they'll get pale,
Okay.
but you get pale from a lot. I got pale when my kid was little. So. Well, the first one,
They said, "Aw."
yeah. She had shoulder dystocia. So,
In most cases, won't you see it on the abdomen, there's a massive amount of internal bleeding?
What was,
Like, kind of like abrasions, but they're not really bruises, but like a discoloration of the skin, so like.
not really. So there can be, there's certain signs you might see on the belly, Kerr sign, Cullen sign. Like you start to see some bruising around the belly button, some bruising in the flanks, but we don't see that stuff right away. Okay, that sometimes takes hours to develop. Just like, well, when we get into kind of secondary assessment with time, we'll have to kind of wrap that up next week. Like bruising behind the ears, we call that battle sign. That can indicate a fracture to the base of the skull. Or bruising around both eyes, we call that raccoon's eyes, and could potentially be associated with a skull fracture. It could also be associated with getting punched twice in the face. But we don't know. You know, so we would assume raccoon's eyes, battle signs, which I've only seen it once on a live patient in my entire life. I've seen it on post-mortem exams. Again, not much you're gonna do with that. The kind of the last thing I check in that initial exam is gonna be the pelvis. And with the pelvis, if you can imagine, you've got your iliac crest, which is the part of the hip that you can feel on the outside here. And then kind of right about mid-groin here, you'll feel a bone that goes across, and that's called your pubis symphysis. So this structure is kind of all held together, and you can have pelvic fractures, and you can have open pelvic fractures. So what we're kind of assessing for, what we're able to assess for, is an open fracture, but it's very hard to identify. So you can have actually an open pelvic fracture in our assessment, like it feels stable. So what we're gonna do is, we don't wanna take a person and rock them too much, especially trauma that we're worried about the neck. But I like to grab these iliac crests. And what I'm gonna do is I'm gonna push them in, and I'm kind of looking to see can they easily move? You know, if I grab everyone's iliac crest and I push in, like it won't move. But if one side kind of moves, that could indicate pretty bad pelvic fracture. So I'll push them in, and then I'm gonna kind of put my hands on the top, and I'll give it a little push, and does it move? And then the last thing I do is I come over here to the pubis symphysis bone, and I just kind of push on that. And so what I'm mostly trying to see is if that elicits pain or movement. If someone yells ow or screams, it's a pelvic fracture till proven otherwise. I don't think I have ever had a live patient where I've been able to move or dispose. And I've had a lot of pelvic fractures that we found out later, but I pushed, did this, and it stayed solid, okay? But pelvic fractures can be life-threatening. Now, a pelvic fracture is different than a hip fracture. Hip fractures are
Inside
where
the
the,
joint,
what's it?
inside the joint.
Yeah, so it's, you know, the femur bone goes into that ball socket in the hip. And you can get a dislocation where it pops out. Or you can get sometimes a fracture of the femur or a fracture of the ball. That could be a hip fracture. But that issue's in the femur. It's not the pelvis. So the pelvic bone, one fracture in there, so if I crack the pelvis, that can bleed almost half a liter of blood in one pelvic. And in most traumatic pelvic fractures, there's usually 5 or 6 different fractures associated with that one injury. So just a pelvis being a traumatic pelvic fracture, we could potentially be 3 to 4 liters of blood loss. So pelvic fractures are surgical emergencies. So that's where I kind of stopped my initial exam. So again, I did the airway, breathing, X, ABC, neck, chest, belly, pelvis. Now I go into my next step, which is vital signs, history taking, and everything like that. Well, Jason, you're forgetting about a few markers. I shouldn't, a lot of times we forget the back, depends on what position they're in, but I should take a quick glance at the back, and all I'm looking is make sure they don't have a stab wound or some massive hole. That's really all I'm looking for at that point. But the arms and legs, the only thing life-threatening would have been a bleed, which I would have found during the X-ray, right? So if you've got a broken femur, broken arm, you're not gonna die in the next few minutes. So a lot of the assessment, we're gonna come back to that. I did that rapid. Now, if Ian is a chest pain patient, obviously, I'm not ripping his heart, looking at his belly, pushing on his pelvis, right? That would be more for a trauma patient. So if he was a medical complaint, I'm not worried about his pelvis, I'm not gonna check it. I'm gonna look at his chest, I wanna see symmetrical movement. I'm still gonna do some modified physical exam, but where I'm really opening, touching, and pushing is more for trauma patients, okay? So I do that to identify immediate life threats. Now I will transition to getting some vital signs. So you can see if we have a person choking or severe respiratory distress, we may show up in the ambulance and EMR doesn't have any vital signs. And that's okay. But rather you focus on, okay, you're working on getting oxygen, we were bagging him, he had a radial pulse. That's my vital sign. Good. So we go on that. Once we've got the immediate threats, now we can try to get vital signs. And I do want to just go into brief history taking. So there's an acronym that I think was talked about called SAMPLE. This is one you want to commit to memory. So SAMPLE is the acronym we use for any patient we encounter that questions we want to ask during the assessment. So regardless if it's a chest pain or a leg fracture, is signs and symptoms is the S, and that is what we are observing and what the patient is telling us. So a lot of times that's what their chief complaint is. So what's wrong? What's your primary complaint? Well, my leg hurts. I can't breathe. I get chest pain. Signs, and so he's telling me his symptoms, and signs are, what I'm seeing. So that's kind of done almost organically without really thinking about it. The A stands for allergies. So are you allergic to anything? Specifically, are you allergic to any medicine? And I don't really care that you're gluten intolerant. I wanna know, like, if you take this medicine, does your throat swell up and you quit breathing? So we like to get allergies because especially in paramedics, we're gonna be giving medicine. And that might be, like, I would say that's probably one of the most important questions you ask someone, because if they go unconscious, that's the one thing I'd like to know. Fortunately, a lot of the medicine that we give as paramedic, we don't, you don't see severe allergic reactions. We're not doing antibiotics or, really like sulfa allergies, we don't really have any sulfa type that, so it's, but the patient will tell you, well, I'm allergic to this. You know, and it's good to know about environmental allergies, so I'm allergic to bees, you know, I can't eat shrimp, and I can't have moxicillin. Okay, good. Just write that down. The M stands for our medications. So at the EMR level, it's really not important for you to write down all their meds. We just want to know, yes, they are on medications. You know where you can find them, or do you have a list? And if they don't, let's say if they're up here vacationing, if they happen to know off the top of their head, that's great. And if they don't have them with, or they're not sure the name, we can even go, well, what do you take the medicine for? Well, I take one for my blood pressure, I take one for my cholesterol, one for my thyroid. Okay, that's good too, to take medicine for this, and this. And we can start to narrow it down from there. So we did SAM, now the P stands for pertinent medical history. Pertinent is huge, because I don't need to know about your tonsils removed when you're 4. But I usually, I kind of summarize big body systems, like, hey, how's your heart? Anything you're currently being treated by a doctor. How's your heart? Do you have diabetes? Do you have seizures? Ever had a stroke? So I kind of hit the big ones. L stands for last meal. Not only is it's not so much a reflection on nutrition, but really that's important for me because I want to know how full is your stomach. Because people who just ate, I'm a little bit quicker to give an anti-nausea or anti-vomit medicine, because what do sick people do? They throw up. So if you just ate 20 minutes ago and now you're having chest pain, there's probably a good chance that you go south, and it just helps me prepare for what the company's full stomachs. And then E stands for events leading up to. So whether it's a chest pain, well, I was watching TV, or I was cutting firewood, that's all has importance. Or we go to a house for a 7-year-old female that found on the floor. So did you trip and fall? Or did you become dizzy first and then fall? Two completely different things. So eventually, that's a sample, and you're going to use that on every patient you go on. And we're going to refine how you ask the questions a little bit. The last acronym I'll go over tonight that will cut you loose is OPQRST. So this is what we use to assess origin and severity of pain. It's predominantly used in like chest pains or belly pain. We don't necessarily use it for like traumatic pain. So if you broke your leg, I'm going to ask parts of it, but not every component. So where we use this is, imagine someone complaining of mid-abdominal to chest pain. Pain's here. So the O stands for onset. And onset is almost the same thing as the E in sample. What were you doing when the pain started? So if you already asked that, you kind of go to the next one. But you know, a chest pain that came on during exertion is a little bit different than chest pain that just came on while at rest. So onset's important. P stands for provocation. What makes it worse? So with that patient has pain here, I will just ask, is there anything that you're doing or have done that made this pain feel better? You know, or they might say, boy, because when people are in pain, they immediately start doing things on their own. So if they say, boy, if I do this, it feels a little better. Okay, so, is there anything that makes it really bad? Well, if I lay back, it gets really, really, really bad. Okay, so that has significance. You got kind of, when it leans forward, the pain gets better. When it lays back, it gets a lot worse. Okay, and then that means something. So, and it's just subjective. We're asking open-ended questions to the patient. Is there anything that you're doing that makes it better? Anything that makes it worse? Q is quality, and that's, again, very subjective, but we ask the patient, can you describe this pain? And if they say, oh, what do you mean? Well, is it a dull, an ache, come and go, constant? And we want in their words, and I don't like to give the patient ideas, because a lot of times they'll just grab it, yeah, we'll use it. No, I want you to tell me in your words. And so we're just documenting what they're telling us. So if they say, well, it's really not, it's not pain, it's just a really big pressure. It feels like I've got, like I've got some bricks on my chest. That's very significant. So that's your quality. Your R stands for radiation. Does the pain radiate out from your brain? So one thing I like to do is I like to ask the patient, okay, point to where it hurts the worst. And go like this. Okay, does it move from there at all? And they might say, well, it kind of goes down my left arm, or it kind of goes up into my jaw. That's radiation. The S stands for severity. And the pain scale I use is on a scale from 1 to 10, with, we're on a scale to 10, with 0 being absolutely no pain, and 10 being the worst pain you've ever had in your life. It's going to give me a number. And it's super subjective, okay? And we're not only looking at how the person's responding, but we're taking that number too. And I'll give you an example. If you ask me how bad, Corey, ask me what kind of pain I'm in.
On a scale from 0 being no pain to 10 being the worst you've ever had,
Oh, it's a 12.
it's 12, okay?
Do I look like a 12? No, and so, you know, where I would document, you know, patient reports a 10 out of 10 or 12 out of 10 pain, however, was, displayed no evidence of pain. You know, displayed no evidence of discomfort. So, you know, I'm asking, it's a very subjective number, and what Corey thinks is a 10 is different than what Vanessa thinks is a 10. Right? Everybody's a little different, it's super subjective. But we take that number because as we get therapy, I want to know, this is what we started with, what's our pain doing as we grow? You know, our goal is to get that number. And then last thing, the T stands for time. What time did the pain start? And we can dive into that a little bit, where sometimes it's, the patient really can't quantify it very well. So, well, you know, I woke up today and it's just kind of been getting worse through the day. Or I'll even ask, okay, it started today, has this ever happened before? Has it been kind of like this throughout the weekend, especially with chest pains or when I'm worried about the heart? Most MIs, I would describe it as an intermittent crescendo a couple days before something happened. So, you know, now that you mentioned, maybe like 2 days ago, I sat down and had a glass of water, pain went away, so I went about my day. And then yesterday, it happened again for, you know, maybe half the day, it was feeling kind of funny. And then today, now it's constant, and it's not going away. That all is very, it's very good to collect all that information. It definitely helps us, and even, you know, the hospital even more. So, with that, I think I'm already going too late. I'm, again, sorry about kind of me not being here on time tonight. But, so next week, what I'm planning on the schedule is we're going to continue patient assessment. I'm going to kind of finish going through the secondary or detailed exam, and we're going to kind of practice on one another. I won't make you uncomfortable touching, but And if we have time, I'm gonna kind of get into the pharmacology, some of the meds we give, and maybe get into some injections. The following week is just one big lab, so all we're doing is lab, okay? So I will get the handouts to you within the next week. Thank you.
Thank you.
Thank you.
Thank you.